Okay, here we go. This is the next step, 2016 next step, chapter 11. This is the female genital and maternity chapter. Begins with just some female maternity, female types of procedures. So 11.1, this is in the emergency room. The patient is having right adnexal pain, so that's a specific kind of or location of abdominal pain. They're thinking it may be Mittelschmerz, which is pain when you ovulate, but they're not sure. So this one's pretty straightforward. This gives some good information and reminders about your different approaches, whether it's a vaginal approach, abdominal approach, laparoscopic approach. Really kind of good synopsis of stuff. 11.2, this is a consultation outpatient for postmenopausal bleeding. They did have an abnormal pelvic ultrasound, which didn't necessarily give any other diagnoses. So to justify this consultation for this moment in time, I think that the reason this doctor or the reason this consultation or visit is going on is because of the postmenopausal bleeding. And then they'll determine if they need to do something in the future. Colposcopies, colpo meaning vagina, scopy meaning a scope or looking at. This is actually a picture here of a cervix, is what you see up in there. 2B, hysteroscopy. This is the note for a hysteroscopy. Procedure performed is generally where I go first for the action. Your post-op diagnoses is here. It's also at the end of the note. They're saying that they did a scope with dilation and curettage, so they scraped out the uterus. Then they say they did an exploratory laparotomy for lysis or adhesions or lysis of the adhesions. They ended up doing a total hysterectomy, bilateral salpingo-oophorectomy, so that's the ovaries, the tubes, and all of the uterus. They didn't leave any of the cervix. And then a Dr. Sanchez came in and did a cholecystectomy. So just kind of coming through here, you see that they had a scope. They saw that there was a perforation in the uterus, and this tells you that it was an accidental puncture during the surgery. So then they converted the scope to a total abdominal hysterectomy, which means it's an open approach now. Here's the adhesolysis, or getting rid of the adhesions. They talk about here the bladder was advanced. They're talking about the different ligaments and stuff here, pulling that uterus free. So from a action standpoint, you've got your total abdominal hysterectomy. That's your big dog. That's what I would do first. But you're going to have to track that scope, because it's probably through the scope that they got punctured. So I would code the scope. It did serve a purpose on this particular procedure, and then put a 59 modifier on it. Your diagnosis codes, they're going to have the endometrial cancer, so make sure you find endometrial. And then you're going to have a puncture intraoperative of the genitourinary. Okay. Operative, your 2C is the cholecystectomy that's going on at the same surgery as this abdominal hysterectomy, but by a different doctor. The patient had a porcelain gallbladder or a calcified gallbladder. You know it was open because the patient was already open. So you're going to use a 52 modifier for this cholecystectomy because the patient was already open, already had another procedure done, what I would call the big dog. The reason that they had to go in there is because of that cancer or suspected cancer. So this gallbladder removal is more of a secondary. So put a 52 modifier on it for reduced services, and then your diagnosis code for the calcified gallbladder. 2D, this is an oncology report. It's an inpatient consultation for that endometrial cancer. You guys should get that one fine. 2E is a discharge summary. This patient ended up having a few cardiac things go on during her stay. So you have to kind of read this discharge summary. Now remember, you have two codes to choose from for a discharge, your 3.8 or your 3.9. We do have 45 minutes stated over here, so you're going to get to use your 99239. So the patient has endometrial cancer. She has a porcelain gallbladder. Those would obviously be listed first. That was the reason she was in the hospital. But she ended up having some cardiac issues. She's got Wolff-Parkinson-White syndrome, which you can look that up. It's a cardiac issue. And she has atrial fib, which they're having to anticoagulate. So I would add those two things too, because it appears in the hospital stay they were medically managed. Some of her other stuff I don't necessarily know if there's anything else in here that's really pertinent to her care this visit, but these two new diagnoses would be, and we've got medications to back up, and probably some referrals. So I would definitely code them. Okay, 11.3, this is a history and physical, which means it's an admit into the hospital for pelvic pain and pain with periods. They end up on this history and physical, they make the decision to have the surgery. I'm not sure what surgery she's having. She's got total abdominal hysterectomy. So I would go on and put a 57 modifier on here. I think it's your answers have it. I kind of get why they have it, but I would kind of get why you wouldn't have it, because I'm sure this lady was in the office with the doctor before getting admitted and knowing that she was going to have surgery. So I don't know. But you can or not. It doesn't matter. It'll be very clear cut on the board when you use your 57 modifier. So for this note, the patient has, or this admit, the patient has endometriosis with chronic dysmenorrhea and pelvic pain. And I would just go on and put all three of those. Although I do think the pelvic pain is a symptom of the endometriosis. But this doctor wrote them all out, and who am I to say that she might not have pelvic pain from something else? So I would just go on and leave it on, because pelvic pain's weird. Some people have endometriosis and don't have, I don't know. So I would go on, since he wrote them out. That is how I would code it. 3B. Operative report for ureteral stents. This is a cystourethropy, insertion of bilateral ureteral catheters. The patient's diagnosis is endometriosis, which is kind of weird. So I just always like to make sure that we're actually doing things bilaterally. So here we've gone into the left ureter. Attention was then directed to the right side, so that'll be good. From here, these stents, we go right into this hysterectomy. So it says here that the patient proceeded with a total abdominal hysterectomy. So that's kind of where we are here. So same patient, endometriosis, a total abdominal hysterectomy. Here's that cystoscopy with the ureteral catheters that we had just done. This is a little confusing. In the real world, it would all be on one note, or you would have each doctor's note. Would be a little different. So this is a little strange, but it's okay. Your procedure code here is going to be your total abdominal hysterectomy. I did want to go back to those ureters, make sure, since they're right and left, that you're doing it bilateral. Make sure that you account for both sides there. So you have your adenomyosis, which is that endometriosis. You have ovarian endometriosis here, and you have the cervicitis. And I think you actually get those 3 from here on the path report. This is a little convoluted in my opinion. So there's your chronic cervicitis. Your adenomyosis of the uterus is that endometriosis, and then you have endometriosis of the ovaries as well. So determine your level, and then there's your diagnosis codes. Discharge summary, no account for time, and then your diagnosis codes would be the same. So you're good to go on that. 11.4, hysterectomy. This is for dysfunctional uterine bleeding. They did a subtotal abdominal hysterectomy here. They left part of the cervix. Why anyone would do that? I understand that they're wanting recovery better. My suggestion to you is don't ever leave part of the cervix. If they're going in there, they need to take it all. So that's just my 2 cents. Cuts down your risk of any problems in the future. So they do actually talk about leaving the cervix here. So make sure your hysterectomy code accounts for that supracervical. And then you have your endometriosis. Path report, pretty much the same thing, endometriosis of the uterus, or part of. 5A, this is a DNC, dilatation and curettage. They used a scope, hysteroscopy, to do it. The specimens or the biopsies that they took is actually the part that they scraped. That wasn't real clear in here, so I'm kind of giving you a hint. Specimens were taken to the lab, so you can consider that biopsies. It's not like it was done. It makes it a little strange because it wasn't done with a needle or a punch biopsy or something like that. But that is what I would do here. And then the patient has endometrial cancer. Okay, moving into maternity care. This does a good job of kind of talking about whether it's vaginal or C-section. Your diagnosis codes will be divided in trimesters in the ICD-10. You will also most likely always need to have a weeks code. Little bit of good wordy stuff in here. We'll get to some of the complicated C-sections or the reason that they had to have C-sections, and I'm probably going to suggest maybe you make a list of if a patient has to have a C-section and can't have a normal vaginal delivery, maybe make a list of the different code areas you need to cover so that you make sure you get all of the codes, because gosh, they got a lot of codes. I'm telling you, it's crazy. And then you add twins to it, and it gets crazy. So, okay, so 6A, this is a volunteer or a voluntary sterilization. This is done postpartum. Your diagnosis code would be encounter for sterilization. It's a Z code. And then here's your discharge. The sterilization was done a day or 2 after she delivered the baby. So here you're going to have a normal vaginal delivery as your first diagnosis code, single live birth, and then the sterilization. Now, if you have normal vaginal deliveries with or without episiotomies, with or without vacuum extraction, that doesn't matter. If it's a spontaneous vaginal birth, which is kind of how they write it, then that's going to be your first diagnosis code. Then you have to have a Z code. This is on the mom's chart. Then you have to have a Z code stating whether the birth was live, single, all of that. So, and then generally, if they were not sterilized, that's all the codes you would need. One for the normal vaginal birth, and one that it rendered or it produced a live birth, single, in the hospital, whatever the criteria is. This particular one, we have a third code because of the sterilization, and it's a Z code as well. So you have one O code and 2 Z codes for this. Okay, 7A is real-time ultrasound. We're going to have lots of ultrasounds in here. This particular ultrasound found that the mom, she's 22 weeks and she has a malformed placenta. So you're going to go to pregnancy complicated by, so I would write that down. Very, very common, a place that you go when the pregnancies are complicated by something is pregnancy complicated by. 7B, this is later, 7 weeks later. Now they're 29 weeks. It appears less grossly prominent, but that malformed placenta is still there. 7C, I thought at first this was like the same patient. I don't think it is, or I didn't think it was. But so I made a note that it's not the same patient, because I kept reading here and I was like, what in the world? What happened to that weird placenta? And it just wasn't there. So 7C appears to be a completely different patient. They'd had a previous C-section. Macrosomia is a large baby, larger than it should be. And then this baby ended up being a breech presentation, and specifically it was a footling. So this is the C-section report. Kind of a weird thing you don't normally see. This woman had some kind of nevus on her abdomen. So while they were going in to deliver her baby, they just cut the nevus out. So you're going to have the diagnosis code for benign skin lesion, which is, just kind of boom there. You're not going to have any kind of skin procedure code. It appeared that this was very close to where they were making their initial incision anyway, and it was kind of draining and stuff. Kind of was not appealing to me. So I think that was just kind of a bonus that they took it out. But so they're not going to charge for it, but you are going to have a diagnosis code, because if there's some kind of complication from that in the future, you have to have proof and a diagnosis code that it existed. So I would still do the D235 for that. Okay, so then we're going around. They found the infant was found to be breech with double footling. That means both feet were down. There's just standing there. Well, obviously laying down, but standing with his feet headed out. So this is going to be the one of the complications to this C-section. So from a procedure standpoint, this is not hard. You just find a C-section and postpartum care CPT code. Now, from a diagnosing standpoint, I have 1, 2, 3, 4, 5 diagnoses. That skin one is just kind of a freebie weird thing. You normally wouldn't have that, but it would be very, very common on a C-section with a malpresentation or something complicating having a vaginal delivery. Would be very, very common to have at least 4 diagnosis codes. So your first diagnosis code has to be the delivery, whether it was a normal vaginal or a C-section. This particular one, when you go to pick delivery by C-section, you're going to have to pick the previous C-section, because this lady had been previously sectioned. Your second code, delivery complicated by the footling. This is a breech presentation. This lady probably would never have had this vaginally. They just don't allow that anymore. She would have had to be at home to have it. Your third code is going to be pregnancy complicated by this macrosomia, this big baby, because the baby, even if it was turned right, could have gotten stuck down in the pelvic girdle and the head couldn't have passed. We don't know. So that it's complicated by that. Then you have that weird skin lesion in here. And then so that one isn't normal. What's normal is how did they deliver? This one was C-section previous. What are the complications? And if there's more than one complication, you have to list those. Could be 1, 2, or 3, 4, whatever. And then your last code is that Z code for the outcome. On the mom's chart, you always have to track that there was a live birth, stillborn, single baby, double baby, triple baby, whatever it is. You always have to have a Z code to track the outcome, and that's how you would reference it. So some trigger words that help us find these in the ICD-10. Pregnancy complicated by, delivery complicated by, an outcome of delivery. All right, and there's a little bit of discussion here that might be good for you. And then you have some pictures of what the malpresentation is, that kind of stuff. Okay, so 7D, this is a discharge. What was interesting to me is they changed the excessive growth of the baby. They changed it into oversized fetus. Not sure why the lingo changed, but that's that on here, that your answers are going to say oversized, but I still see macrosomia. May still sequence to the same code. I didn't have time to go back and check that out. Usually I don't code every single thing. So just kind of be aware of that. If you look at the answers, it's going to say oversized fetus, and this still says macrosomia. May be the same code. 11.8. This is an admission into the hospital. Remember, just throwing out a little bit more information about these pregnant women. If they're 37 weeks or greater, they're considered term. If they're 36.6 days and under, they're considered premature. This mother had a spontaneous rupture of membranes. She's got twins cooking in there. She's 34.3 days. So they're going to be considered premature. And they're breech as well. And I'm not sure if both of them are breech. We'll get to that in a minute. But this is the admit going into the hospital. So from a CPT standpoint, determine your level. And then from a diagnosing standpoint, you got to have, number one, that she's pregnant with twins. That's why she's being admitted. She had a pregnancy complicated by this spontaneous rupture of membranes. She's before 37 weeks, so it's a premature rupture of membranes. Probably not for a twin pregnancy. She's doing pretty good, to make it almost to 35 weeks. But it's still considered premature. So then you have pregnancy complicated by the breech. So here we've got twins. We've got spontaneous rupture of membranes prematurely. And we have complication of the breech. And then you would need to go on and log how many weeks she was, because she's not term. So you would log 34. You don't round up. If they're 34 up to 6 days, then they're just 34 weeks. You don't track the day part. Okay, here is the C-section for this lady. 34 weeks, twins, spontaneous rupture of membrane. She's in active labor, and then she's going to want to get sterilized after this, which I probably would too. I don't know if this is the lady. She's got, oh yeah, she already has 2 other kids at home, and she's had some problems, I think, getting pregnant. So I'd call it good too. Okay, so she ends up having 2 viable female babies with a breech presentation of baby B. So that's going to have to be a complication. Remember, any kind of weird presentation is a complication. One baby weighed 5'6". One baby weighed 4'12". So those are good sized babies. My 5'13" was my biggest baby, and my smallest one was 4'8". So these are a good sized baby. They're okay, especially for twins. So, okay, so let's just kind of look here. The first baby was delivered to the chest. They bowled him out and handed him off to the staff. Then they were able to palpate the second infant who was breech. They got a hold of the hips, ruptured the membranes for them. I guess it was baby A's membranes who ruptured first. And then they delivered this one to the chest, bulbed it out, and handed it over. So we're all good to go. And then I think now we get into, did we fix her? Yes. The mesosalpinx, the tube was transected using the bovie. So we did do, and I probably should have highlighted all that. I don't know, I guess I got tired of this. They looking at the left tube, the distal end, blah, blah, blah. Okay, so they ended up sterilizing her. So from a CPT standpoint, you've got your section, and then you have that add-on code for at the time of C-section, they have sterilized them. It's that add-on code. From a diagnosing standpoint, it's a little bit of a nightmare, but we have talked about a few of the things. So start thinking about the list you need to make for these more complicated deliveries. So the very first thing, we have to have twins C-sectioned in the hospital. Okay, so that establishes that they were sectioned. Then we have to tell why they were sectioned. You have to have a medical necessity for being sectioned. So they had delivery complication of a breech. Then you had a delivery breech with obstruction. That one baby who was all the way breech wasn't going to be coming out. That would have obstructed. With two in there, she was probably blocking the way for the other one. So you had breech with obstruction on baby B. You had breech with A, but it wasn't obstructed. Although A wasn't a breech baby, it was still a breech delivery, even though one of the babies wasn't. So you have one with obstruction and one without. Then you have that pregnancy complicated by premature rupture of membranes. You have your outcome of live twins. So you're done with all your complications. Now you have your outcome of the live twins. And then you have your desire for sterilization, which after that, she made a good decision. Okay, discharge summary. Kind of a synopsis to some extent of some of the other codes you've already done, but you don't have to have them in quite as much detail. So you've got your CPT for going home or discharge. You've got a twin pregnancy, C-sectioned because they were breech, and the malpresentation. I think that the answers got a little strange here. I want you guys to look at code 032.1XX1 and 032.1XX2. Your answers have both of those, and I know they're accounting for baby A and baby B. So just look at both of those. Then you have your Z code for the live twins, and then you have your Z code for the sterilization. OBs can get super duper complicated in my opinion. Okay, 11.9 is an OB consultation. She is pregnant. She's got type 1 diabetes with diabetic nephropathy. This was not caused, this is not gestational. She already had it before she ever got pregnant, so it's going to complicate the entire pregnancy. And they're going to have to account for it the entire pregnancy. Okay, so this is an inpatient consultation. She is how many weeks? 30 weeks. Yep, she's 30 weeks. So you've got, she's coming in for the nausea and vomiting and diarrhea. So she's caught some kind of some kind of GI bug, I would imagine. Although they don't concrete tell you that. So you still have to code out the vomiting and diarrhea. So I would do an O code with pregnancy complicated by vomiting, and it's not vomiting because she's pregnant. It's vomiting from an other disease or an other virus. She's caught a bug. Then you have the hypertension that she has. She has chronic hypertension, complicating pregnancy. And then she has diabetes type 1, pre-existing, which is complicating her pregnancy. Then on top of those O codes, anytime you have disease processes that are complicating a pregnancy, you have to code that disease as well. So you have to code E1021 because of that diabetes type 1 with the renal nephropathy. You need to code also the diarrhea. She's got diarrhea here. And then you've got to track her weeks. Lots and lots and lots of codes. And she's 30 weeks. And that's that funky Z3A code. So here, 9B, they're going to do a ultrasound on her legs. She's got some swelling. This lady does. Different than this lady, I think. Who can tell? Nope, it's the same name. I don't know. So you're going to do your medicine section ultrasound code. Then you're going to have your pregnancy complicated by a specialized or a specified condition. You're not going to be able to find suspected DVT or DVT. You're just going to have to go with specified. You know what it is, you just can't find it in the book. And then you're going to have the leg swelling, M code for that leg swelling. These get really crazy complicated, and it's really hard to flow through the book. Real world, it would be a little bit easier to code these, so don't get too discouraged. It's okay. For the board, you'll have all the codes sitting there, so you'll just have to determine if they're applicable or not, which in some ways is easier than having to come up with them on your own. So 9C is an antenatal screening for an amniotic fluid volume. This is a fetal test. So your diagnosis codes, you're going to have two. One is a Z code for the antenatal screening, and one is a Z code for the weeks, and she's 29 weeks here. Biophysical profile, again, is looking at the fetus because of some pre-existing issues with the mom. So this is a fetal biophysical profile based on mom's diabetes type 1. So your diagnosis code is going to be that O code for pregnancy complicated by diabetes type 1 pre-existing. And then you have to go on and list the diabetes on top of that, which is E10.9 for a type 1. Remember, on your type 1s, you do not track insulin because it's inherent to the disease process. It's only type 2s that you track insulin on, if they're on insulin. 9E, this is a Doppler, looking at the umbilical artery for the baby because of this renal nephropathy that the mom has, or this insufficiency she has with her kidneys because of her diabetes. Then they're having to look at this. So again, you're going to have that O code for diabetes, a pregnancy complicated by diabetes type 1 pre-existing. Then you have your chronic hypertension. So hypertension complicating pregnancy with that pre-existing renal disease. And the renal disease is the nephropathy. And then you always have to code also the actual specific diabetes, or whatever that is. 9F, boy, we'll be glad when this is over. This is a limited ultrasound. The woman is now 32 weeks. She's had some threatened, she's in for preterm labor. So this is threatened labor before 37 weeks. So you're going to have pregnancy complicated by threatened labor, and then you're going to have to track the weeks. The Z3A point be 32 in this instance because she's 32 weeks. 9G, now she's 34 weeks, and they want to check the maturity of the lungs of this baby. So it's another antenatal screening. And then you'll track the weeks. the Z3A.34 this time. 9H, amniocentesis. Your diagnosis codes, they're 32 weeks, which I would track. I don't think your answers had that, but I would track 32 weeks. They're the insulin dependent, type 1, and they have that renal disease. So you're probably going to come up with more codes than your answers did, probably based on what I just taught you. 9I, OB ultrasound, 34 weeks. Again, this is an antenatal screening. It's just a follow-up to make sure that everything looks okay. Antenatal screening, and then you'll track the weeks, which are 34. And now I think we're actually going to get to section this baby out, thank goodness. And I'm not even sure that they're all the same baby, because we've got 32 weeks and 34 weeks and 33 weeks, and I don't know. But this particular op report for the C-section, the mother is 33 weeks. She does want to be sterilized. She has a desire for sterilization. She's had a previous C-section. She does have the diabetes type 1 with the diabetic nephropathy. It's just a single baby, I think. Holy cow, I hope so. So from a CPT standpoint, you're going to do your C-section with postpartum care. We don't know about prenatal care, but we know postpartum. And then she desired that add-on code for the tubal. Diagnosing, you have pregnancy complicated by diabetes, the type 1 pre-existing, all of that. You have pregnancy complicated by the hypertension. You have preterm pregnancy complicated by preterm delivery, because this woman is just 33 weeks. You have a delivery by C-section, which I would code that first. Delivery by C-section for this note. This is the op report, so I would do delivery by C-section. Then you can do all your complicated bys, and I don't know that it matters that much, you know, order-wise. Since you used that pregnancy complicated by diabetes code pre-existing, you've got to list also the specific diabetes, so that's your E1021. Then you have your outcome of delivery. Remember, you have to track how you delivered, and you have to track the outcome. You pray for spontaneous vaginal deliveries, I'm telling you, unless you really like this kind of stuff. I don't. I did never like this kind of nursing either. It's just me. So the outcome of this was a single live baby. She desired to be sterilized, so you got to have that Z code. And then because she was preterm, before 37 weeks, which is considered term, then you're going to have to track how many weeks she was when she gave birth, which is 33. And holy cow. Okay, so now we got the path report on her. We have 3 specific specimens, A, B, and C. So we have a placenta, we have a left tube, and a right tube. So that's kind of what you're seeing here. So make sure your levels, your pathology levels, account for all 3 levels. Then you have your pregnancy complicated by diabetes, your pregnancy complicated by the hypertension, which I think is all that they've put up here. Yeah, you've got your type 1 here, diabetes, you have your hypertension. I would go on and put the O code for O3421, delivery by C-section. I would do that first. I don't think your answers had that. And then you're going to need, because you've listed that pregnancy complicated by the diabetes pre-existing, you've got to have your diabetes E code on here too. Holy cow. And that's it. Yay, good for us. We made it through and it didn't kill us.